Hello and good evening, everyone. Welcome to the SAB's May Educational Webinar event, the Pediatric Consult, Building Teams to Meet the Needs of Advanced Bronchoscopy in the Pediatric Patient with Dr. David Shore and Dr. Jennifer Toth. Before we begin, a few reminders to our audience and anyone new to the SAB webinars. Everyone right now is in a listen-only mode and you guys are muted. If you have questions, we do encourage you to submit them by using your control panel. There's a question feature located there. We'll address all the questions during the Q&A portion after Dr. Shore's presentation. At this time, I'll hand it off to SAB's past president, Dr. Jennifer Toth, to get us started. Thank you.
Good evening, everyone. It's my pleasure to introduce Dr. David Shore. He is currently an interventional pulmonology fellow with me at Penn State at Hershey. He is also a pediatrician by boards, and this gives him the very unique capability and opportunity to become an expert on the meshing of pediatric and adult interventional pulmonology. He will be staying on as faculty at Penn State and remains a valuable resource to our colleagues who are interested in breaking into this field. So I will leave you to David's excellent presentation, and we will have a question and answer at the end.
Thank you so much. Hi, everyone. So this is going to be a pretty informal talk. Feel free to list any questions you have in the chat where Jen will be paying attention, kind of letting me know as we go. And thank you all for your time this evening. And without ado, let's get started. So our only relevant disclosures is that Dr. Toth has worked with Spiration for some time, and one day someone will care in such a way about me as well. So we're going to be starting and talking about pediatric advanced bronchoscopy. And I thought it'd be useful to really kind of start by discussing where we are, the scope of the problem, and then starting to explore some of how to approach the pediatric patient, a mental framework to use, and then some of the evidence that may or may not support some of our decision making. So this case report from 2002 was the first case report to really describe the novel advent of advanced bronchoscopy in children. For the longest time, pediatric bronchoscopy was limited by size and availability of tools. And while adult interventional and advanced bronchoscopy has really started to take off over the past 2 decades, in 2002, it was considered novel to take a scope, approach a consolidated lesion in a patient with an abnormality, and do a transbronchial biopsy. And that was worthy of discussion and case report and the founding of a field. Since then, we have exploded, and we're truly in an exciting time for advanced bronchoscopy in children. We have our first international community statement for advanced bronchoscopy in children. We have our first textbook, and we have a variety of reviews, case reports, randomized control trials, and even multi-center studies. They range from things like talking about advanced bronchoscopy via EBUS, EUSB, and navigational bronchoscopy, cryoprobe for children, cryoprobe therapy in terms of extraction and freeze-thaw cycles, as well as endobronchial valve therapy. Now, in talking about where we are and what the perception of this growing field is, it was really interesting to explore this exact question with our pediatric colleagues 1 year ago, where we surveyed 28 programs over 25 states, all major academic programs disseminated through both division chiefs and program directors of fellowships. And we asked the question of who's doing what and with what experience. What we are interested in trying to explore at the time is, with this booming field of things like EBUS and cryoprobe, how are pediatric pulmonologists starting to address these problems, and how are they getting the experience to do so? Now, one of the most interesting things we found at the time was already 31% of our colleagues in pediatrics identify themselves as either an interventional or advanced bronchoscopist in children. But I really think we have to ask the question, as advanced bronchoscopists ourselves, what does that mean? And so, taking a look at their procedural confidence, we asked the question about some of the basic things that you and I might do on a daily basis, things like endobronchial brushings, endobronchial biopsy, and even something like transbronchial biopsies. And you can see that here, confidence for even just something as simple as brushing was only in the 67% for very confident, And then the next highest two were in transbronchial biopsies at 25% and things like mucosal biopsies as well. This isn't particularly high, particularly when we're trying to talk about things like the utility of EBUS, convex versus radial, and cryoprobe debulking. This level of procedural confidence is similarly mirrored in their procedural volume, even though 1/3 of our pediatric colleagues are identifying themselves as advanced bronchoscopists. If you take a look at those, for example, who are performing convex probe EBUS, it's about 1 to 10 a year per provider, with no one cracking the 10 marker. These are uncommon procedures for our colleagues, and there remains questions about how they're going to get experience and who they're going to work with to try and treat these patients. So when we ask the question of, is pediatric advanced bronchoscopy feasible and should it be trained to our fellows, the answer is overwhelmingly yes. But then the question of who should be performing these procedures and in what sorts of teams is where we start to see interesting data. Surprisingly, 2% of these pediatric pulmonologists thought that adults should be doing it, which is the uncommon opinion. Overwhelmingly, they thought that pediatric bronchoscopists should be involved in the cases, which I would agree with. And as high as 1/4 to 1/3 of all respondents thought that only pediatric bronchoscopists should be doing these procedures, which is, I think, something of interest and something that we should perhaps aspire to, but we should ask the question, are we there yet? Now, if we're going to be talking about pediatric bronchoscopy, we really have to be mindful about Robert E. Wood, who frankly is the founder of pediatric bronchoscopy. During his time at Cincinnati and his time internationally, he's founded courses to teach advanced bronchoscopy for the past 40 years, and he's developed with Olympus some of the first pediatric scopes capable of doing these kinds of things. When he's asked about things like advanced and interventional bronchoscopy, he's quite frank, and historically he hasn't always been a major proponent of it. He says he feels so strongly that there should be a grease chute to the most appropriate center of excellence with experience and the qualifications to handle these patients who have interventional needs. Now, the question of what is the center of excellence and who has the qualifications to do this, I think is relevant. And when we talk about getting called as the adult provider to potentially participate in these care, he specifically comments that the pediatric airway are and should be a frightening place for the adult bronchoscopist without specialized pediatric training. Now, he goes on to add that perhaps there's a binary in terms of age distributions, where at the age of roughly 12 years of age, the patient has developed both in terms of size and physiology to be similar enough that adult bronchoscopists should be able to handle it more independently. Everyone younger than that age, he makes a significant argument, should be having the experience and the collaboration with pediatric colleagues. Now, when we talk about who these pediatric bronchoscopists were teaming with, it kind of all over the board. We are not, as advanced bronchoscopists in adult medicine, the number one or the number two. More historically, they've teamed with pediatric ENT. This is because as the advent of advanced complex airway disease in children has evolved, historically, pediatric ENT has been the realm of those who do rigid bronchoscopes and tracheoscopes to evaluate for things like agenesis of airways or fistulations or clefts. And to the point that now most advanced bronchoscopists in complex airways have something they call the triple scope, where you get a rigid ENT, a flexible pediatric bronchoscope, and a GI endoscope all roughly at the same time to evaluate airway issues at the same point. But when we're talking about who else to team, it's kind of across the board. It could be pediatric general surgery. It could be adult thoracic surgery in the right situation. And so knowing who to potentially involve in your team when you're asked to take care of the pediatric patient can be very useful. So what we're going to do now is we're going to introduce a general conceptual framework, and I want you to be able to use this to apply to any pediatric consult that you may or may not be asked to see moving forward. The first question is, knowing my skills, how can I make my procedure safe in a pediatric patient with perhaps differences that I'm not as able to account for? The next question is, how are children different? What's their differences in terms of disease and pathophysiology, and how do I have to account for that for my pre-procedural planning? And finally, knowing how can I make this safe? How are children different? Who should I be teaming with both in the operating room and outside of it to better care for these children? So frankly, when I get questions in the children's hospital, it's not usually problem focused as much as procedural focused. They'll ask me something like, could you put a valve in this? Can you biopsy that? Could you please put XYZ and XYA? And so the first case that we're going to try to explore today is the 15-year-old, 30-kilo child who comes in with a significant travel history abroad with failure to thrive. Now, we define failure to thrive slightly differently than we do in older patients. Failure to thrive is usually falling off of your growth curve, perhaps having a delay in terms of your bone maturity or lack of secondary sex characteristics. This is useful because while we might be talking about B symptoms in adults looking for things like a cold infection or lymphoma, it's not as apparent in children where they can have more subtle findings where they're just not appropriately gaining weight. So let's meet our patient. I'm going to stop talking for a moment and show you some of these scans. So as you can see, as we're moving through them, here is what they asked us to biopsy. We're going to come back around. You can see it correlated over here. And so our pediatric surgery colleagues have been asked to perform potential VATS and surgical removal simply for diagnosis of this hilar mass. And they had reached out to us knowing some of our capabilities and the history of working with us over the past 15 years and said, I really think that this could be amenable to a bronchoscopic evaluation, and can you help us? So the first question from our conceptual framework was, how do I make this safe? Like, I do mediastinal and hilar evaluations all the time in adults, but what do I need to know about the unknown limits of pediatric disease? So when we're trying to describe what's safe in children, what I think is a really useful first step is to ask the question of what's been done before, because while we are in rarefied air, we're not the first to potentially tread foot here. So this is one of the earlier case series of single center experience from Johns Hopkins from Gilbert et al. Describing their experience with advanced bronchoscopy in children. Now, if you look down about halfway through, you'll see all of these are the patients that they are evaluating with either convex EBUS with a linear probe or conventional TBNA, although overwhelmingly it was convex probe EBUS. You can see there was an age cutoff of around 10. No one younger than the age of 10 in their study was amenable to this kind of bronchoscopy. And I think we have to ask the question as to why. Now, when we talk about the pediatric airway, size really matters, and smaller airways limit bronchoscopes. Traditional historic training for pediatric intensivists and anesthesiologists try to correlate and estimate what would be the appropriate endotracheal tube size for a patient based off of their age. And you can see we have the Cole and the Duracher formula, and these both are trying to describe uncuffed versus cuffed endotracheal tubes as a function of age divided by 4, plus 4 versus plus 3.5. And this generates this table for for potential endotracheal tubes in children. And as you can see, these are small. There's a very difficult, it's not very easy to get the 6.9 outer millimeter diameter of the EBUS scope through a 4 cuff, a 4.5, or any of these other airways. We really need something that's potentially larger, not just to accomplish and allow for the passage of the scope, but also to allow for adequate ventilation. Similarly, when we're talking about laryngeal mask airway size, this is a very useful table to give you a rough idea of potentially which patients can you get this through. Ideally, you want something like an LMA 3 or a 4, and you're seeing that we're starting to come up across a weight limit of potentially 20 kilos, and that can be significantly limiting in this potential modality for children. That being said, is size truly the limit that we think it is? And again, when we're asking the question of what's safe and what's been done, Gilbert et al. Later on explored a multi-center study in pediatric bronchoscopy, and they found that their youngest patient who's ever received EBUS was 1.5 years of age. Now, this did require significant kind of limitation and modification of their bronchoscopic approach. What they did is they passed the bronchoscope through the airway, found their lesion, biopsied it, and then removed it to allow their pediatric anesthesiologist to ventilate and oxygenate and catch back up, so to speak. But this does speak to the fact that perhaps the age of 10 and the weight of 20 kilos is not the firm limit that it really need be. This is similarly being found in advanced bronchoscopy with robotic software. This is the only case report of robotic software being used for bronchoscopy in children because As you know, the Monarch system generally recommends an 8.5 endotracheal tube, and similarly, the endoluminal ion on a whole recommends larger endotracheal tubes as well. But because of its outer diameter being only 4.2 millimeters in size, they were able to accomplish this biopsy with a 6.0 in a young child. That being said, they weren't able to get their tools or their scope all the way to the edge of where they wished to. They were about 2 centimeters away from the lesion of interest. But as someone else who performs a lot of robotic bronchoscopy, 2 centimeters can be doable. Okay. There are other ways to potentially make this procedure safe and circumvent the size challenge. And some of those things include things like EUSB. A lot of interest is also being found in radio EBUS, where you're using the radio probe, which can go through a smaller working channel to either go into the sorry, my mic turned off, to go into the periphery, or frankly, to identify your central lymph nodes and then use conventional tBNA. This might be why in most case series and randomized control trials looking at advanced bronchoscopy with EBUS or EUSB in children, the most commonly biopsied sites were 4R and 7. Now, finally, let's take a look, perhaps in aggregate, about what some of the data is saying about bronchoscopy for the hilar mass in children or lymphadenopathy. And these are the number of the studies that have tried to ask this question, all the way from 2010 to just recent this year with one of our other colleagues at SAB, Dr. Corcoran. And you can see that their youngest patients are similarly breaking this age barrier of 10 as young as 0.75, although it's important to know that in the Groussard patient population, they are only using conventional tBNA. Or in the 2024 study as young as 2. Further things to consider when you're going to be doing advanced bronchoscopy is planning for complications. And so as we're trying to talk about preoperative planning to make things safe, it's important to recognize that the pediatric patient is different, not just because they're not a little adult, but also because they're smaller and their needs for medications is much less. Something that I think takes getting used to, for example, is how much saline to lavage. There's a number of calculations out there, but for example, in pediatric dosing, usually they'll do 2 to 4 aliquots at 10 milliliters per aliquot, or if they're younger than or older than the age of 6, they'll use 20 milliliters per aliquot, maxing out at a dose of 4 milliliters per kilogram. Similarly, you have to be very mindful about your lidocaine usage on the way in. And if you run into bleeding, which is defined as massive only in the context of 8 milliliters per kilo in these patients, you have to be mindful of there are some differences in the application of epinephrine. That being said, and I recommend people look into this when they have more time, the weight-based dosing for children is code dose endotracheal epinephrine, which is much higher than what I use on a general basis for adults, which is a maximum dose of 0.6 milligrams given 10 to 15 mics at a time versus 0.1 mg per kg in adult children with a max dose of 2.5. This might be why, for example, there's been more reported side effects of arrhythmias seen in children. Continuing on with our algorithm, first we started with how do we make this procedure safe? Now let's ask the question of what's different about children's pathophysiology. And the most common cause of hilar adenopathy or kind of mediastinal and hilar masses in this population isn't what we're used to, which are solid malignancies. It's much, much, much more commonly represented by things like infection. Frankly, almost all of the EBUS and EUS studies that have been done outside of the United States have been done to evaluate patients and the likelihood that they have tuberculosis. Outside of things like infections, particularly things like mycobacterium, we're talking about patients who are much more likely to have lymphomatous diagnoses. And then sometimes we're getting into more single-digit diagnoses, things like lymphoma or small blue round tumors or things like carcinoids. But these are much, much, much less common. And frankly, this is a bug. It's not a bug, it's a feature. When they're talking about the use of advanced bronchoscopy in children, their biggest question is how do I increase my microbiologic yield in patients who really need it? Taking a look at the figure 1 on the left, this is talking about the addition of radial EBUS to the biopsy of peripheral consolidations in immunocompromised children. And what they were interested in was that it doubled the diagnostic yield of relevant microbiologic data. Similarly, if you take a look on the figure 3 on the right, this is the 2024 Corcoran study. Frankly, they're talking about how transbronchial biopsy is, whether it was robotic, navigational, although theirs was only navigational, and EBUS, their point was that it increased the yield of clinically significant pathogens. And then when we take a look at that same table from earlier, asking the question of not what was the youngest patient that did it, but what diagnoses were they seeing, overwhelmingly we're seeing, like I said, is tuberculosis, lymphoma, and sarcoid. This means that when you're getting your specimens prepared, it's really important to be preparing it in the appropriate way. Things like making sure you're getting tissue culture and making sure that you're planning for things like flow cytometry and that you have a pathologist who's capable and ready to evaluate for both of these things, which isn't always true in the Children's Hospital. Now, finally, we ask the question of how do I make this safe? And then what's different perhaps about pediatric disease I need to be aware of going in? The final question is, with this information to our, at hand, how do we build our team? With the overwhelming diagnosis of things that are infectious or malignant in etiology, particularly things like lymphoma, I think it's really important to be mindful that outside of the operating room, we really need to be coordinating with our infectious disease and pediatric hematology, oncology colleagues. Now, we spend a lot of time with the adult world doing this as well, but it's common that the people who are going to be asking you to biopsy these things haven't necessarily involved them in the first place. So you need to be mindful that you need to sit down with everyone, all stakeholders, and make sure that you all have the same plan and same mental model moving forward of how you're going to try and diagnose this. Then when you're in the operating room, in addition to incorporating pediatric pulmonary providers so that you can start training them and building a program that includes their ability to take care of these patients as well, I think it's really important to be interacting with pediatric anesthesia and pediatric general surgery. This is because for the anesthesia colleagues, we want, if we're going to be doing something as crazy as occluding the airway every 5 minutes to take a biopsy, we need an anesthesiologist who's okay with a little bit of a fun ride, so to speak. Furthermore, we're talking about things that diagnoses that EBUS has typically struggled with, particularly things like Hodgkin's lymphoma. And when you look at any of the case series in multi-center trials that we described earlier, their biggest challenge was having to do a redo procedure. And it's the pediatric surgeon who, if you're unable to get the diagnosis through the fact that EBUS struggles with these diagnoses sometimes, that they're the ones who are going to follow up with a more definitive biopsy. And this is more of a summary side of how do we made it safe, how are they different, and who do we build into our team? Safety being that we know that we can really push these procedures into patients as young as 18 months of age, as long as we're mindful of which tools we're going to be using and how we're going to accommodate things like differences in size. Then reflecting on the fact that the diagnoses are different and we need to be testing for different things when we're down there. And finally, that we're bringing the appropriate team so that when we either run into trouble or when we need follow-up procedures, that we have the right people who are already on board. So now we're going to be moving on to case 2. Case 2 describes the question of, can you place a valve in this patient? This is a frequent call, most particularly from our pediatric surgery colleagues and the pediatric ICU. Now, this past winter was horrific, I'm told, for pediatric lung disease. And this was because there was a lot of group A strep and influenza associated with strep pneumonia, necrotizing pneumonia. And so this young patient came in just this year, 6-year-old with necrotizing pneumonia and a persistent air leak who they can't wean. They've even tried to change out the chest tubes over a wire thinking that maybe that would be of benefit. Just like before, here is our patient now. And you can see this patient has ECMO cannulas placed above and below. Here is our space. And you can see that the necrotizing pneumonia was broad, particularly in the lower lobe, but it was extensive. And I'll run that one more time since I was jabbering away. Okay. So using our same mental model, trying to ask the question of how do I have to alter my plans to make this particularly safe for the pediatric patient. Then we'll be discussing how is this patient different and how do I modify my approach based off of that and who do I need in the room with me. The first things first is perhaps the answer to keep this patient safe is we don't have to do the procedure at all. Now, we're all experts in pleural disease, but our pediatric pulmonary colleagues don't always spend the same amount of time discussing things like chest tube management as much as we do. Similarly, our pediatric intensivist colleagues and our pediatric surgery colleagues don't have necessarily the same volume as persistent air leak disease that we have. And so the first question should be, is there another way that I can manage this patient that I'm familiar with that they may not be? Often that's something like an empyema tube, where you leave them on water seal for a while, or in the situation where you can't wean from suction, reach for the same tools I already reach for, which is an autologous blood patch. Now, the question I think you have to ask in children is what volume and who is this safe in? But this case report describes the application of a 3 milliliter per kilo arterial blood patch to a neonate who was only several days old with significant success. Taking a look at what literature and data is out there to support this, we see the study by Pruitt et al. This is a different population. These are all surgical patients with persistent air leak after surgery, and they required anywhere from 1 to 3 dosages of blood patches, and each time they used 2 milliliters per kilo. You can see there's some disagreement on how much the volume is, but there's some disagreement in the adult population as well. So then, frankly, my first step most of the time is to talk about whether a blood patch is appropriate and something that we can try. And I would note, going back in terms of safety, this patient population, they clamped every single one of these patients during the blood patch application, which is not something I recommend doing when they're on suction with a persistent air leak. This study, they did not clamp them. They did the exact same thing that I do with adults, which is where you take the tubing, you put it up high, so the blood doesn't get out, but the air does. Now, moving on, if you determine that the safest thing for this patient is to place a valve, then we're left with Dr. Toth's excellent case series and her experience from earlier in the past decade describing 4 patients who had various forms of influenza and necrotizing pneumonia. And she describes that she was able to place endobronchial valves in a patient as young as 1.3 years of age. Now, some of the technical specifics that she goes through are steps that we're all particularly familiar with. They're all inspiration because of the FDA compassionate use exemption. They use the tapered Olympus hybrid scope, the 160F, and I do think it's important to be mindful of which scopes you're going in with these patients. They use that to identify the airway of interest. They occluded the airway with the sizing balloon, and then and only then did they try and use, if they could, the adult therapeutic scope to deploy. Now, just from what we're seeing here, there are some challenges that come to mind, and you can take a look. You can't fit the adult therapeutic scope in a child who's less than 2 years of age. It's just not doable. Now, this is important for us to talk about because the deployment catheter requires a size of 2.6 millimeters, and almost all of the pediatric scopes, whether it's the 160 or the 180, most of these have a working channel of 2 millimeters at most. This presented a unique challenge for her, and what she was able to do was she placed the bronchoscope and the deployment catheter alongside each other using forceps to help guide it into the position of interest. If you have any questions, she can go into this in much more detail, and it's very, very interesting. Okay. And this is exactly what we're describing, taking a look at the 160 versus the 190 and the 180. Even if they're slightly larger in terms of their outer diameter, you can see their working diameter channel is 1.2 versus 2.0. And this, frankly, is a significant limitation to doing it through the working channel as you're used to. Okay. Now, finally, when we reach the third part of our mental model of trying to build your team, in addition to, again, including pediatric pulmonology to help build their skill set and build a program of excellence that's interested in doing this kind of work, I think the people you have to include in your team inside and outside the OR is the pediatric ICU and our surgery colleagues. Our surgery colleagues are already the people who have been managing this disease process for years. So getting them on board with new modalities of thinking and new techniques is useful in building a multidisciplinary team. The next population of people that you really have to get involved with is the PICU. The PICU has been historically places their own chest tubes and manages it themselves, and they're the ones who are taking care of these incredibly sick patients, and they're the ones who are going to be calling you. Now, it's important when you build your team to be sitting down with them because you're going to want that they have an understanding of what's going on and what you did for their patient. Otherwise, the calls later in the day or into the evening can be more confusing. Now, just some of our final take-home points. So when you're moving forward to try and ask questions of how can I help my pediatric colleagues with their procedural question, first ask questions about safety preoperatively. How do I have to modify my approach or my team to accomplish what I need to do in the safest manner possible? Are there other modalities of treatment outside of what they're asking for that I have experience with that I can apply? The second question, as always, is using your pediatric consultations to build the question of how is the pathophysiology and perhaps the differential different than what I'm used to? How do I have to approach this problem differently in terms of my sampling techniques to meet that need? And then finally, who do I want to build my team? Who do I really want to work with so that A, we can become a program that's able to continually address these problems, and B, so that we can provide patients with safe care in and outside the operating room. And with that, that's everything. I'm just going to stop sharing my screen for a moment to start answering questions.
So thank you very much, David. We don't have any questions in the chat at this point, but I think that we're going to be seeing a lot more interest as practitioners, especially with children's hospitals affiliated with them, start to think outside the box and trying to solve some of these very difficult pediatric cases, both with airway and with pleural disease management. By expanding, pediatric pulmonologists' skill set as well, I think is going to be quite important, because if you're going to be taking on these advanced bronchoscopy procedures, then dealing with the complications is going to be something that is imperative. You need to have a team, but you also need to be able to troubleshoot immediately. So with that, I will turn it back to Emily. Thank you for your attention this evening, and have an excellent night.